Well, good morning, everybody. It's an absolute pleasure to be back in Newcastle. I'm Dr. Stuart Hanna, CEO and co-founder of MicroPlateDx. I'm joined today by my colleague, Ali Longmuir, MicroPlate Product Development Lead. And also in the audience, we've got fellow co-founder and chair, Dr. Poonam Malik, who'll be around all day as well. So MicroPlateDx, essentially, we started life as a University of Strathclyde spin-out company, spun out just under 4 years ago now, really with the mission, a threefold mission, if you like. So firstly, accelerating treatment decisions for patients around making sure that they get the right antibiotic treatment first time. By doing so, transforming patient quality of life. And lastly, through pioneering our antimicrobial stewardship enabling diagnostic tests. So this is making sure that antibiotics are only given out when they're needed, and if they are given out, patients are getting the right one first time. So we've got a highly committed and experienced team within the business, from 4 of us that co-founded it, alongside highly influential board members. They've got that experience spanning the technical and commercial, and also experienced in growing, scaling, and exiting biotech businesses in the past. Alongside a plethora of experience across our senior management and advisory capacity, spanning technical, operations, and finance. And we're particularly proud of the clinical advisory panel that we've been able to amass, including Dr. Ashley Price here in Newcastle as well, from NHS Foundation in Newcastle, but basically feeding into the development of the rapid plate system that we're developing. And the problem that we're tackling at MicroPlate is antimicrobial resistance, and the big challenge healthcare professionals face every day with making sure that they're giving out the right antibiotic first time. So in terms of the antimicrobial resistance challenge, or AMR, it's close to 1.3 million global annual deaths attributed to AMR. And if that is left unchecked into the future, by 2050, that could reach 10 million, which would be more than cancer and diabetes combined. As I've touched on, the real key challenge that clinicians are facing every day is the fact that it currently takes anywhere between 2 to 3 days once you send a sample to a microbiology lab for culture and antibiotic susceptibility testing to get those results back. It leads to vast empirical or guesswork, essentially, as to which antibiotic is needed for the patient, which is exacerbating the challenge of AMR, but in some circumstances can then lead to fatal sepsis. So it's absolutely imperative that new point-of-care diagnostic tests are developed, which are able to rapidly speed up that time of getting the right antibiotic to patients and ensuring that they're only given out when they're needed. And if we consider how the field of antibiotic susceptibility testing has evolved, it's really remained largely unchanged for decades. That notion of streaking out bacteria on petri dishes or agar plates to see whether or not they're able to grow. We want to revolutionize this field through our rapid plate technology. So we've taken that concept of the agar plate but simply miniaturized that down into little hydrogel-based deposits. These help promote bacteria growth. We embed antibiotics into these gels. It fundamentally behaves very much like a petri dish, except we're able to pick up very subtle electrochemical changes, such as impedance, through this system, meaning that we're able to do all of this at the point of care in under 1 hour, versus the current standard, which takes 2 to 3 days.
Yeah, and so just to build on that a little bit and just to bring it to life a little bit more is that, if a standard, I would say, use case is if a woman is feeling like she's got a UTI and has got some symptoms there, she will present herself to a pharmacy and she'll go there and she'll be given an antibiotic. She'll probably be given a dipstick test. She may well be given a dipstick test, she may not. But even just to bring the AMR problem to life, in Glasgow, if that woman were to go to a pharmacy there, she would be given a choice of 2 antibiotics and a broad spectrum, which is still a problem because they're broad spectrum. But if the lady were to present in the northeast of England, she would be given a choice of 1 antibiotic. So 150 miles difference, we've already seeing antimicrobial resistance between 2 major cities in the UK. So that sort of brings to life the reality of the problem that we're seeing here. So with our system, what we're trying to do is actually provide that evidence to kind of make an informed choice, to give a more personalized prescription of the antibiotic through our point of care system, where we provide a cartridge, we've got an instrument, urine sample applied to the cartridge inserted in the instrument, And we'll be able to give three pieces of information there. We'll give some information on the bacterial growth that's been detected, or if there's bacterial growth, we'll also provide an indication of the species of that bacteria as well. And we'll also be able to give them a sort of more personalized prescription of the antibiotic. And we can do all that in a matter of about 60 minutes. Now, when you compare that to if a GP were to suspect that there was maybe something going on there, they would go and get a kind of a central lab-based test. That could take up to 2 to 3 days for that result to come back, by which point she may well have to get her prescription changed. It's a real problem. And in actual fact, we got some data recently, just last week, from a study that we did through working with Newcastle and so forth, is that even in some cases, they're waiting for 14 days for a result to come back. So that becomes quite serious when you start thinking about the repercussions of sepsis. Next slide, Stuart. So getting into the science a little bit more, what does our system look like? So in that cartridge, we've got 32 wells, almost like miniaturized petri dishes. They're antibiotic-laden gels, and within the cartridge, we've got 6 antibiotics, 2 broad spectrum, and 4 narrow spectrum antibiotics. And within that, we're actually able to, by applying some of our electrochemical magic, we're able to analyze that cartridge analyze those cells for bacterial growth. And then we'll be able to provide an indication of within each of those cells, was the specific bug, was it susceptible or resistant to that antibiotic? And then what we can then do, we can provide the clinician a more personalized indication or picture of what would be effective for treating that bug there. And so does our system work? I know it's a bit of a messy slide here, lots of graphs and lots of numbers and so forth, but the key takeaway here is we've run about just in 2024, we ran 3 independent studies, one in Newcastle, one in Glasgow, and actually one in India. So combined there, you can see we're getting really good sensitivity, specificity with the AST component of that, and then with species ID, and being able to identify the bug, we're getting up to 97% accuracy there as well in bug identification. And so, yes, it does what it says on the tin, as they say.
So in terms of the market opportunity, so we're targeting the global antibiotic susceptibility testing market. It's worth over 5 billion globally. But urinary tract infections is our initial indication. It's about 40% of that market. And there's a real clinical need, as you've heard. There's about 150 million UTIs reported globally every year. But what's really stark is 1 in 4 sepsis cases can actually be linked back to an earlier poorly treated UTI. Again, imperative that you get that right treatment first time. In terms of us, widespread applicability for this test, that notion of moving this to the point of care away from central labs. So you're talking about potentially pharmacies, primary care, even within hospitals, accident and emergency and urology wards being key drivers for this across the globe. And we had some health economics performed on the test as well, just to show the financial piece behind this. And savings of up to about £155 per patient can be achieved simply through that earlier intervention in the care pathway and avoiding patients then ending up in hospital and all the repercussions of sepsis alongside. In terms of kind of our USPs and position within the market, so we really set out to develop this test to be incredibly simple to use, incredibly fast, but also incredibly cost effective as well. So we've effectively scaled up these miniaturized kind of agar plates using something akin to, say, the diabetes test strip industry on these sort of electrochemical based gold systems. So it is incredibly cost effective to purchase. It's incredibly fast. As we say, we're doing all of this. We're doing the growth detection, the species ID, and the AST in under 1 hour. It's very simple to use, as the usability studies we've performed in Newcastle and beyond have shown. But what really stands us apart is the fact we're doing all of this phenotypic AST, giving us true susceptibility and resistance with the species ID in under an hour. That really is quite unique in terms of the market. There's companies out there doing perhaps the AST part, or doing the ID, that sort of thing. But doing the two of these together in that time frame at this cost, really, we believe will put us in a really good position as we start to drive this to commercialization.
And so coming on to our evidence generation side of things, so as you saw previously there, I showed a bit of technology and showing, does our technology work? Yes, it does. And we believe our technology is fantastic, as we would, because we developed it. However, as I think most of us in here that are involved in product development know, it's a real product development of medical devices is a real grind. And there's quite a large graveyard of people that thought their technology was cool, but it didn't make it to market, and that's probably a conference all of its own of the reasons around that. But however, one main reason is lack of or ability to overcome reimbursement and adoption hurdles. So evidence generation is a huge part to play in this. And this is where our relationship with the team in Newcastle has been great. I've got to give a real shout out to the team. I would get them on the stage to embarrass them. I did say that earlier, but I'm not going to do that. But it's been a great one-stop shop to get their input, and be working with the HRC to help on our HRC, the Neil, Newcastle University as well. But also we've got some external partners that the Newcastle team have always also been collaborating with us on, working with third sector charity, Live UTI Free, with patients with real lived experience, and they're helping to bring that all together into some evidence generation studies for us. And this is what we're doing with the Newcastle team. As I say, I think it's a great one-stop shop, and I don't mind plugging them because they are fantastic at what they do. We've got a strategy around PPIE and working with the Insight panel, and that's provided a lot of great input into our product development, but also our clinical study design as well. We're also doing kind of qual studies with focus groups across secondary care, and working with the health economics team. And also, we're about to start early next year, working with the team in Neil, doing an evidence generation study there, performance validation study on our product as well.
So just to sum up, in terms of the business, just been going for about 3.5, 4 years now. To date, we've raised over 7 million in private equity investment and grant funding across a number of rounds. Get some very supportive investors on the cap table as well, which has been fantastic to help drive this forward. And been recognised widely as well, both from the kind of commercial positioning of the business as well as on the technology itself, including double Barclays Award winners for the startup of the year and the health life sciences company as well. So thank you very much for listening to us, and happy to take any questions.
So thank you very much to Stuart and Alistair. I couldn't have written that better myself if I'd tried. So that's just a perfect description of exactly what we're trying to achieve here. And I hope it illustrates the power of those sort of collaborations if we get them right. We'll take some questions, and Nick's got his hand up already right at the back. So Nick.
Yeah, hi, Nick Reynolds from the HRC and Newcastle University. So great presentation, really enjoyed it. I wondered as well whether you could give examples where you've avoided giving people antibiotics on the basis that they've had symptoms but no actual growth on your test, because that would also be a massive change to behavior, because that I think is perhaps an underestimated element.
It's a really good point. Often symptoms can present, but actually it doesn't reach that UTI threshold, which is that sort of 10 to the 5 colony-forming units per mil set point. And at that point, you're absolutely right. At the moment, there is no way to be able to determine whether or not an antibiotic should be given until it then goes for culture and AST. And often, that is too late because an empirical antibiotic will have been given out. So that is very much what we're trying to do with the technology. It's as much about ruling out the need for the antibiotic and then perhaps looking at more treatment options as for then ruling in. If the technology is sensitive enough that it can pick up way below that 10 to the 5 threshold, then you can then see whether or not that's needed, which is why initially, before the species ID or the AST outcome is presented, it's about identifying that actually the growth is there and it's at that threshold to be able to then make that informed decision. And I think, there is a movement then in terms of the kind of data piece that comes off the back of that and the adoption, because in the moment when there's no testing done, patients expect often to walk out with something, and often that's something that can be given as a prescription. But if you've got the data through a rapid test to then say that actually, okay, we can investigate this further, but there's data to say that you don't necessarily need that antibiotic first time, I think that's a really powerful driver from what we've heard from the groups. But actually that is enough to then satisfy them, at least initially, that they don't then need to get that broad spectrum first time.
We've got time for one more question, and then we will have to move on. Down in front, Angela.
Thanks very much. A great presentation. Can I ask, have you tested it on elderly women in care homes who have a normal biome of bacteria growing in their urinary tract anyway? And can it differentiate between that normal biome and what could develop into sepsis?
Great question. So of the testing that we've done to date, we've actually taken a very broad approach. So within that, there's absolutely going to be samples coming in from that care home setting with that exact scenario. We're able to differentiate between a lot of these different settings actually coming in. Typically, it has, so it's not just been, say, uncomplicated, it has been more complicated UTIs as well, and those without. So the sensitivity is enough that it is starting to pick up that differentiation. But as this drives forward into more kind of pivotal studies, care homes for us and those sort of scenarios are absolutely key to then start carving out where this would then eventually be adopted. But yeah, it's a great point.
Just a little bit of a build as well that the current studies we're doing as well at the moment, we're actually looking at various different use cases within the care pathway, and that's back to that, I didn't say too much about it on the thing, but the evidence generation that we're doing at the moment is really about where in the care pathway do we get the biggest impact with this. So we are actually looking at even specialist niche cases such as spinal injuries, for example, gynecological units, urology, but also into some of those primary care settings as well, from pharmacy, CDCs and so forth.
Okay, thank you very much indeed. That was fantastic. Are you going to be around for the rest of the day?
We're here till about lunchtime.
Okay, so it's going to rain in Scotland, so they've cancelled all the trains.
Yeah.
Stuart and Alistair are going to have to get on a train at lunchtime.
Yeah.
But I can say that. You can, yes.
Harsh but true.
But anyway, if you want to catch Stuart and Alistair, they'll be around at the break. Thank you very much
Thank you
indeed,
very
guys.
much.
Okay.